Hello everyone. Today in MemoMap we are going to answer a simple question. How does cardiac output change during the exercise? But before we start, let's start with big picture. What is the cardiac output? The cardiac output is the volume of blood pumped by each ventricle every minute. Notice the word every minute. Why it's important to remember it is an every minute, because we are talking about the volume of blood pumped per one beat. If we are going to talk about the amount of blood pumped per one beat, this is called a stroke volume and not a cardiac output, but the volume of blood pumped per minute, this is the cardiac output. So remember, cardiac output equal the heart rate multiplied the stroke volume. And it's important to remember that to increase the cardiac output, we need either increasing the heart rate or stroke volume. But however, if the heart rate increase markedly above the 140, so the ventricle has less time to fill, shortening of the filling time during the diastole, and this will decrease the cardiac output. And on the other hand, if the heart rate decreases markedly, less than 60 per minute, the cardiac output decrease, and this is because the limited capacity of the heart. What about during the exercise? Well, during the exercise, remember that both heart rate and stroke volume increase. However, according to the trainee status, we have a difference between the untrained and trained. In untrained, the heart rate increase dramatically, while the stroke volume increase within limit. The heart rate increase up to 200, while the stroke up to 50%. So in untrained, depending mainly on the heart rate to increase the cardiac output, while in the trainee, the story is opposite. The stroke volume increase markedly due to the increase the size of the heart. So the trainee rely and depend mainly on the stroke volume to increase the cardiac output. Let's move to the second part of our MemoMap. What determines the stroke volume? Remember that the stroke volume is the amount of the blood pumped out of the heart in each beat, not minute. So, and it depends in two main volume. The end diastolic volume, which is the maximum amount of blood in the ventricle at the end of the filling during the diastole. And the second is the end systolic volume, which is the blood left behind inside the heart after the ventricle finishes the contraction and the ejection of the blood. So the stroke volume equals the end diastolic minus the end systolic volume. According to this equation, to increase the stroke volume, we need either to increase the end diastolic or decrease the end systolic volume. So first, how do we increase the end diastolic volume? The answer is via increasing the preload. Remember, increase. The preload is how much blood fills the ventricle before it contracts, and the greater the venous return, the greater the preload. So the more filling, the high in the diastolic volume and the higher stroke volume. Now, how do we decrease the insystolic volume? There are two factors, either the contractility or the afterload. Remember, increase the contractility means pushing more blood out of the heart, and this will decrease the end systolic. So the stronger the heart pump, the more blood out, and less blood left behind inside the heart. So the higher contractility, the lower end systolic volume, and the higher stroke volume. Second is decrease the afterload, and afterload is the resistance the ventricle must overcome when it ejects the blood. So if the resistance is high, as in vasoconstriction or hypertension, the heart ejects less blood. So the higher afterload, the higher in systolic, the lower stroke. The lower afterload, the lower in systolic, the higher stroke. Remember this rule. Now, let's apply this on three conditions. First, during exercise, there is increase in the heart rate to the sympathetic and the hormonal, as well as increase in the stroke volume. And the increase in the stroke volume is mainly due to increase the preload and high in the diastole, increase the contractility, and decrease the afterload and lowering of the end systolic volume. What happens when you stand up suddenly? This will pull the blood into the leg due to the gravity, and this will decrease the venous return, and this lowering the preload, and in diastolic lowering the stroke volume and cardiac output. What about the very fast heart rate, as in case of arrhythmia, when the heart rate is above 140? The higher the heart rate, the lower the filling time, because the diastole becomes shorter, so the ventricle do not have time to fill completely. So this will decrease the preload, lowering the end diastole and lower the stroke volume. Now let's move to the third part of our memo map, and here we are going to talk about how do we know whether the heart performing well or not, and here we are focusing mainly on the ejection fraction, the cardiac function curve, and the cardiac reserve. Regarding the ejection fraction, it is the percentage of the end diastolic ejected by the heart. So the ejection fraction equals the stroke volume over the end diastolic volume multiply 100. And it's usually measured by the echocardiography. Let's give an example here. Suppose the ventricle contain 120 milliliters, which is the end diastolic volume, and then after contraction, the remain is 50 milliliter inside the heart. This means that the stroke is 70 millimeter, and to estimate the ejection fraction, all what we have to do is to divide 70 over the 120. So remember, the ejection normal is 50 to 70%, 55 to 70%, so it's normally above the 55%, and it didn't indicate a good ventricular contractility. Moving to the second point, which is the cardiac function curve, and it represents the relationship between the right atrial pressure and cardiac output. Why we mention the right atrial pressure? Because it reflects the ventricular filling, or in the other hand, the preload. And the relationship is straightforward. The increasing in right atrial pressure allows the ventricle to be filled. So the more the right atrial mean the large filling of the ventricle, mean the large end diastole and preload, mean large stroke volume, and the cardiac output increase. So the relationship is direct, however within limits till the plateau is reaches. This is the normal curve for the cardiac function curve. However, the curve may shift up or shift down. When it shifts up, this is a hypereffective heart, and this is occur when the heart rate increase, contractility increase, or the afterload decreased. And it may shift down, and shift down is a hypoeffective heart or disease heart, and it is either due to decrease in heart rate, decrease in the contractility as in infarction, decreasing the heart rate as in parasympathetic stimulation, or the afterload is increased as in the hypertensions. Here you need to remember how is the contractility regulated. We have two mechanisms, the extrinsic mechanisms. Here either the factors are coming from outside the heart, as in sympathetic or circulating hormone like catecholamine or thyroid hormone, or an intrinsic regulation, and this depends on the Frank Starling mechanism, and is also called a heterometric autoregulation. And remember, the Starling mechanisms is a relationship between the sarcomere and the tension. And the more the ventricle fills, the more the cardiac muscle stretches. And remember that the more stretches, the more tension, till we reach to the optimum length, which is 2.2 micrometer. Please remember this number. At this 2.2 micrometer, the tension is the max. After overstretching above 2.2, the tension will decrease, and this is explained by the relationship between the actin and myosin, and the overlap between the myosin and actin is the best when the length is 2.2, and this explains the maximum force of the contraction. So remember 2.2 equal the maximum tension. Moving to the cardiac reserves, what is the cardiac reserve? Is the maximum increase in cardiac output above the resting value according to body demand. Remember, the resting is 5 liters, so during exercise, the cardiac output increase above this may reach to 15 liters. And here, the greater this increasing in cardiac output, the greater is the cardiac reserve. And there are numbers you have to remember. In the normal untrainee, the cardiac reserves increase up to 300 to 400. In well trainee, it reaches to 700. If it's less, either this is explained by old age or by the disease in the heart. What determine the cardiac reserve? We have two, the heart rate reserve, and the maximum heart rate is estimated by the formula 220 minus the age, and the stroke volume reserves is determined by the end systolic, and here we are going to add the size of the heart. Remember, the trainee athlete has physiological enlargement of the heart. This spoke about the athletic heart. The long-term training will result in eccentric or the volume overload hypertrophy. Remember here, the chamber become larger, not the wall of the blood of the heart. And this is a normal physiological adaptation to increase the stroke volume, in contrast to the concentric or the pressure overload hypertrophy, in which the chamber inside becomes smaller and the wall becomes thicker. And this explains the most important difference between the trainee and untrained. In the untrained, remember, it depends mainly on the heart rate, while the trainee depends mainly on the large stroke volume. Now we come to the final part of our topics for today. It's about the oxygen consumption. First, we need to answer the following question: when does the heart need more oxygen? This occur when the heart work harder by increasing the heart rate, increase the contractility, increase the afterload, and increase the preload. But remember that the increase in the preload has the smallest effect on the myocardial oxygen consumptions. Uh, and now comes the question how to meet the increase in the oxygen demand. But before we answer this, remember this golden rule. The rest of the heart already extract about 70 to 80% of oxygen carried by the coronary blood. So this means that the heart cannot meet any further increase in oxygen demand by extracting more oxygen. Rather, it meets the increase in oxygen by increasing the coronary blood flow. So remember this rule: more oxygen demand, as in exercise, equal more coronary blood flow, but not more oxygen extraction. How does the body increase the coronary blood flow? This will be our third question in this part. And this is simple by dilatation of the coronary artery, and this occur by two main mechanisms. The most important mechanism is the metabolic. The secondary mechanism is the neural regulation. Regarding the metabolic regulation, when the heart work harder, it produce more metabolites such as adenosine, is important, hydrogen, potassium, and carbon dioxide, all act directly on smooth muscle, resulting in a relaxation of the smooth muscle, vasodilatation, and increasing the coronary flow and the oxygen delivered to the heart. The secondary mechanism is the nerve, and we have sympathetic and parasympathetic. I know that at first this may sound confusing, but remember that the sympathetic stimulation has a direct effect through the alpha, causing a vasoconstriction. However, the sympathetic stimulation also increases heart rate and the contractility, so increasing the myocardial metabolism, reduce more vasodilate metabolites such as adenosine, and such it cause a dilatation of the coronary. So the direct effect is constrict. The indirect effect is the dilatation. So the overall effect of the sympathetic is coronary vasodilatation. What about the parasympathetic? The parasympathetic decreases the heart rate, such it decreases the work of the heart. so few vasodilator metabolite produced, and such it decrease the coronary blood flow. So with exercise, the heart work harder, the oxygen demand increase, but rather than increasing the extraction, we need to increase the coronary blood flow by vasodilatation of coronary. Mainly, the metabolite play the first and important role to ensure enough oxygen reach to the myocardium to support the increase in the workload. Before we finish, let's recap the today memo map together. Today we learned how cardiac output changed during the exercise. First, we started with the big picture, the definition of cardiac output. Remember that's per minute, not per beat, and it equals the heart rate multiplied the stroke volume during the exercise. Both the heart rate and stroke volume increase. However, in untrained, the increase in cardiac output depends mainly on the heart rate, but in trainee, it depends mainly on the stroke volume. Next, we learned what determines the stroke volume. The equation equal the stroke volume equal the end-diastolic minus the end-systolic volume. To increase the stroke volume, increasing the end-diastole by increasing the preload, decrease the end-systole by increasing the contractility, decreasing the afterload. We apply these concepts for three situations. In three situations, first during the exercise, preload, contractility, heart rate increase, only the afterload is decreased. Withstanding suddenly the gravity reduce the venous return and preload during the rapid heart rate when the heart rate above 140 the filling time reduces decrease the preload. Then we move to how assess the cardiac performance. We learn three important tools. First, the ejection fraction, in which the stroke volume divided over the end diastolic volume multiply 100. The normal value is 55 or above 55, and it indicates the ventricular contractility is good. The second, we talked about the cardiac function curve, which represents the relationship between right atrial pressures and cardiac output. And the curve shift upward, hyper-effective heart, or downward, hyper-effective heart. And the main factor responsible for these shifts are the heart rate, contractility, and the afterload. And remember that the contractility is regulated by extrinsic mechanism like sympathetic stimulation and hormone, or intrinsic mechanism. Intrinsic mechanism is the Starling law. And then remember that the 2.2 micrometer is the optimum scarcometer length for generation of the maximum tensions. And after this, we discuss the cardiac reserve. The cardiac reserve is the maximum increase in cardiac output above the resting normal level according to the body need demand. Remember the following number: 300 in normal untrainee, 700 for the trainee, and lower value for age or heart disease. The cardiac reserve depends on two components. The heart rate reserve, remember the equation: maximum heart rate equal to 120 minus the age. The stroke volume is depend mainly on the three factors, which are the end diastolic volume, the end systolic volume, and the size of the heart. Remember that the athletics heart develop an eccentric or volume overload or hypertrophy in which the chamber enlarged, and this means a large stroke volume during exercise. Finally, we talked about the myocardial oxygen consumption. The heart work harder means it needs more oxygen, but because the heart already extracts 70 to 80% of the oxygen under the rest condition, it cannot meet this demand by extract more oxygen, rather by increasing the coronary blood flow. And the mechanism for increasing the coronary blood flow, mainly the local metabolic vasodilate, especially the adenosine, hydrogen, potassium, and carbon dioxide. Of course, sympathetic stimulation contribute indirectly by increasing the cardiac work and produce these vasodilate metabolite. This is the all for today. Thank you for your watch. See you in next